Skeletal frameworks, the reason why I don't do them. They look really nice, and the theory behind them is that they expose all the gingival margins, which is great for people that have got perio. Obviously the theory being that the saliva can move around the teeth, oxygenate in those areas so that the anaerobic bacteria doesn't thrive under the denture in those areas, therefore it'll be healthier for the gums. And I get that and I understand it. The problem is quite frequently the frames fracture. It's a lot easier to fracture the frames because they're obviously so much smaller. Those little frameworks that are going around the teeth can be thickened up and are thickened up a lot thicker than an actual plate. Plate design is usually about 0.9 of a millimetre. Those skeletal frames are over 2 millimetres, sometimes 3 millimetres. This is the problem that I find with them. Apart from them fracturing, they affect the speech more, in my opinion, in my experience. Primarily, I'm talking about lowers at the moment. They can affect the speech. Also, the food gets trapped in those areas, which, you know, is probably not good, especially for people that have got the perio anyway. You know, you get like a chocolate egg or something stuck in there for a few hours. Most people have lost teeth and need a denture due to poor oral hygiene. So that's what I feel needs to be tackled more than the design of the denture. The denture should be taken out after they've eaten and rinsed out and cleaned so that there's no food stuck in those areas. But we got to remember that the patients that we're seeing usually has got bad perio because they've not cleaned their teeth properly. And I know that's not true for everyone, but for the majority I'd say that is the case. You know, we've all heard the stories, oh, I clean my teeth all the time, and like, yeah, you probably for about 3 seconds. The food gets stuck in there and then that can cause an issue. But these are minor things. My main problem is that if the patient's got really bad perio and they've already lost a lot of teeth, the chances are they're going to lose more teeth. You can't easily add a tooth to a skeletal frame like you can with a plate design. So if you think of a lower denture, patients maybe lost posterior teeth and they've retained their lower anterior teeth, and then you have a plate design going around the back of those teeth as a major connector to connect up those posterior acrylic sections, and then the patient loses a single central tooth on the lower. If they've got a skeletal design, that's really difficult to add a tooth in that situation because there's just nothing to add it to. So what do? We flood acrylic from the posterior region all the way round to connect up to the other region, and we're right back where we started with filling that area in. But worse, because it's acrylic, it's not strong, and the chances are that tooth's then going to fracture off. If it doesn't fracture, you're certainly going to get fractures between the acrylic and the metal framework where there's no attachment point. The bacteria will get in and it go black. It just never works very well, and subsequently that might cause more tooth loss. So we could weld a tag, but again, with a tiny skinny little skeletal frame, that's really difficult to add a tag on without melting it, and I'm sure there's lots of technicians out there saying I could do it. For the average technician, I think they would probably struggle getting that chrome up to a high temperature to tag a little tag on. And even if you do manage to weld a tag on to attach the tooth to, still not going to be that strong. Whereas if we did a plate design on that tooth, it makes it a lot easier to add acrylic, where we would either cut some slots into that framework, that plate, and then add the acrylic that way, or the way I like to do it is by drilling a hole. If you drill the hole, and quite a big hole, as big as you can get it, but then you've still got a metal surrounding that area so that you flow the acrylic through. Generally what you're trying to do in those sort of situations is the acrylic needs to take up more space than the metal. The metal's very strong, so you can keep the metal section quite small. Anyway, that's a technicality, but you can quite successfully add a tooth to a plate design like that, not those skeletal frameworks. So unless the patient is made fully aware that that is the case and that they will have to buy a new denture to successfully then add another tooth where that one's missing. And if they're happy with that and they can afford it, and then in those sort of cases, then maybe it's the right thing to do. But I would say in most cases, when you've got people that've got bad perio and they might even have some slightly mobile teeth and the prognosis of those teeth is not good, then opening up that framework, yeah, I see the benefits of it. However, the long-term plan for that patient, it might not be the best situation. Like I say, if they can afford it and they're happy to then keep buying new dentures every time they lose a tooth. But for most people, if you give them the option and say, look, this is the situation, we might find that that is in fact the way. What they will probably do, and in my experience what they do is they would rather go for the closed plate, knowing the longevity of the denture and that those teeth can just be added. You know, especially if those teeth, if the long-term situation for those teeth is that they're going to be lost, I think that's the best decision, is to make the denture accommodate any teeth that then have to be added. There have been occasions when I have designed the metal framework to both allow the saliva movement around those areas, but with a design of already welding in a tag across that area to make it easier to add a tooth. But those designs can be a little bit tricky, and it goes back to this communication thing with your technician. If he fully understands what it is that he's doing and why he's doing it, and you've got a good technician, then that can be an option. But that's my thoughts on it, which is why I tend to avoid those skeletal frames. Sometimes I say skeletal, sometimes I say skeletal. I don't know which one's right. Which term do you use? I think that there are occasions when I will use a skeletal frame, but for the most part I use plate design. I'd be interested to know what you guys' thoughts are and whether I should be changing what I do and offer those skeletal frameworks more, or do you think that I'm right in saying that if the prognosis for the patient's teeth is not good anyway, that we should be looking at the plate design? My other thought on this is that if you do add a tooth and it's on a plate design, the dentures then tend to fit better, which means you get less movement. And again, I think that this is much better for the remaining teeth. So a denture that's not fitting properly can cause huge amounts of damage to the existing dentition, whereas a denture that's just clipping in is quite firm and it doesn't jump about in the mouth is a lot better and will help. In situations I've seen, a denture that fits really well can actually help stabilise teeth that have become mobile, almost act like a splint and brace it in place, and those teeth have then become less mobile. And I have seen this on quite a few occasions where patients presented to me with a denture that's really bad and is literally putting pressure on all the teeth and causing them to become mobile, to changing it to a design that really fits perfectly, holds those teeth in position, and within a few months of assessing them, those teeth have then stabilised and become a little bit firmer and probably healthier as a result, which may not have been achieved if I'd have done the skeletal design. But let me know your thoughts. It's an interesting topic, this one, because it's a little bit difficult sometimes to decide which is the best route to go. Anyway, let me know your thoughts. I'll see you next time.